finally I can start my presentation. Actually, this is the standard Cook device. It is 34 millimeter proximal and 18 millimeter distal, and 2 60 millimeter branch for the renal artery and 8 millimeter branch for the SM and celiac. So the instruction for use is clear that you have to your aneurysm should be within this range to be used for the aneurysm patient. So this is the standard case that the patient is actually the AAA patient without infrarenal neck. For this patient, the T-branch device usually is very easy to use in this kind of patients. So when we deploy it, we just have to see the proximal and distal goal marks. There are many marks in the middle part of the stent graft because each branch have 5 markers on the branch. So actually, when we deploy the device, we just have to see the proximal and distal goal markers and the tick marker. So when we deploy the device, we have to keep the center line, the proximal and distal goal mark in the midline. When they fold in their branch, a little twist is possible. So when we deploy our branch, usually it should be slow and segment by segment to avoid twist of the device. So when the branch engagement is a little bit difficult, you may have to hand the device a little bit higher so that you can have more space to engage into your branch. So this is a typical case that after a successful T-branch implantation, the landing zone area is usually very crowded, but usually the aneurysm sac complete thrombosis is no problem. When we try to apply this patient to treat dissection patients, this is a patient who have a total artery replacement about 4-5 years later, and we have increasing dissecting aneurysm in the abdominal area. So in the abdominal area, the patient's celiac trunk, SMA, and renal artery are all from the true lumen. This is the best scenario for us to perform T-branch in dissection patient. And also the patient's true lumen diameter is about 31 millimeter, which is enough, more than 25 millimeter, enough for us to have the engagement to each branch. So the procedure is straightforward, but actually we use so-called segmental release technique because the space is a little bit small. So we deploy the proximal 2 segment to engage the celiac SMA first. So you have to know that if we put the 12 French sheaths from left subclavian artery, and it is compatible to 8 French sheaths and O18 wire. And if you put a O35 wire, you can also run a 7 French sheaths. Why we have to know that? Because I always put the device into these 2 branch in case that if we did not engage first, after the deployment of the SMA branch or celiac branch, the other branch cannot be engaged anymore. So after we engage the SMA first, then celiac trunk, then we engage the renal artery, and the patient has complete sealing of the tears. But this is the best scenario, but actually in clinical situation, you will have much more complicated patients like this. Actually, the patient have total artery replacement and the petticoat down to the aortic bifurcation. After 8 months, you can see the fourth lumen increase in size significantly. Mm-hmm. So we can see the celiac trunk and SMA both come from the fourth lumen, and the left renal artery comes from the true lumen and fourth lumen simultaneously. And the right renal artery is from the true lumen, but there is a stenosis over the orifice of right renal artery. So for this kind of patients, the diameter of the aorta is also small, only about 20 millimeter. Could we apply the T-branch in this kind of patient? Yes, it is possible. Before we deploy the T-branch device, we have to prove that we can engage the celiac trunk and SMA through the true lumen into the fourth lumen and engage into the artery. Mm-hmm. So before we deploy the Cook device, we engage celiac and SMA, and we prove that we have intima tear that can go out to the fourth lumen.